Good morning from Tanta, from El Grahat Hospital. This is the first case of 3D with this brilliant team, Dr. Bayoumi, Wali Drojdi, Ahmed Rasasi, Salih Sawaf. This is the first case with Insight X. We are proud that the government is supplying this high-tech technology to insured patients and to Nafa Dawla patients. Introduce the case, Rasasi.
Okay, thank you, Dr. This was a 55-year-old female patient. She had impaired ejection fraction of about 45%. Her cardiac MRI didn't show any scar, and the Holter.
She was a PVC patient. She's a PVC, symptomatic PVC patient, PVC running in bigeminy, and the burden was?
The burden was about 25%.
And the ejection fraction was impaired? 45%. MRI was normal, so this is PVC-induced cardiomyopathy. Yeah. Localization here?
So first, when we look at the ECG, we can see that the PVCs has inferior axis, was positive in 2 and 3 and AVF. When we look at the transition, we can see that the transition occurs in V3. So this may be from the RVOT or LVOT, but as we can see that the transition in the PVCs precede the transition in the sinus.
Yes, and also we can see that there is abrupt transition, like QS V1, QS V2, and R, big R in V3. This is abrupt transition. Also look at limb lead 1. This means this is a posteriorly located. If you are in the RVOT, this is posteriorly located PVC, right?
Okay. So we suspect that it's either a posterior RVOT septum or from the right coronary cusp. And this was our plan to map the right and the left side.
So we started with the RVOT. We placed the decapolar catheter in the CS, and we mapped by using a tacticath catheter, which is a very high tech, which measures the contact force. And we, Dr. Muhammad Saeed, our brilliant navigator of PVCs and ablator of PVC, did this. So show us.
So this is where we started the first map. This is our RVOT, and we found some early signals on the RVOT on the posterior side, like yes. Dr. Mirvat said. After that, we also went to the LVOT.
Can you show us some intracardiac signals, please?
Yes.
Well?
Okay. This is the intracardiac signal. This is the 12-lead ECG, and this is the early point here, as you can see.
How early?
This one was around 25 milliseconds early.
So this is 25 milliseconds before the QRS complex.
Yes.
Is the unipolar signal okay?
Yes, unipolar signal here was negative, as you can see.
Okay.
This is where we mapped on the left side. You see we had.
So we right side. We did ablation in this area, and we noticed. Can you show us the first ablation? Or the ablation which suppressed it. There was delay between the ablation and the disappearance of the PVCs.
Exactly.
Can you show it here?
The first lesion?
Yes.
Yes.
The one which showed yeah.
Okay.
And the tips and tricks. This is the tips and tricks.
Okay, this is the first RF session.
Yeah.
Okay, this is where we started ablation.
Yes. Yes.
And you can see after a while.
Still there. I think it was not the first one.
We can check.
Yeah. Stop. Show us the where we ablated.
This is where we suppressed. It's a bit later.
Yes.
But we suppressed around here.
Yeah.
We had PVCs and then it went to sinus.
Yes. But the disappearance of the PVC took some time.
Yes.
And it recurred.
After the PVC recurred, we went to the other side as well.
So we said, okay, if it does take time to disappear, So this means that we are not on it. You have to think different. So instead of going ablating more and more and more, and this can get a risk because this is the RV. So we went to the left side because you remember the localization said the transition at V3, but there is some like abrupt transition.
Exactly.
Okay. We went to the left side, to the right coronary cusp, and we were guided by the site where we went to the right side. So?
Exactly. This was the early spot on the right side.
Yeah.
And so on the left side, it was exactly facing it on the other end, and this helped to localize the left
Show
side.
us best the signal, how it looked like.
Signal. Let me show you. This was
that was
the signal
beautiful
as well.
Also,
also we have a negative
unipolar,
deflection. It's early, and it's around 20 milliseconds early as well.
Although the timing is not that perfect, like from the right side, but look, run when we were ablating this point, because it was only 1 point ablation.
Yes.
It was only one single point ablation. You have to have an intelligent engineer like Wael to have successful ablation of PVCs.
Thank you.
We have to trust. Also, we use the conventional machine to make sure that what he is seeing is what we are seeing, so we have double checking on that. So he will show us where we started ablation from the left side, from the right coronary cusp. This is the ablation.
All right, is RF4, yellow.
Yeah.
Hey.
Right.
Okay, this is where we ablated.
Yeah, this one went immediately. This was mapping. Now, no, this is if you see this is from the onset it was very short immediately, and it went away. We waited for 30 minutes and there was no PVCs, and we were lucky.
Yes.
But remember, PVCs can deceive you. ECG does not give you full answer. So you have to be ready, right side, left side. Don't waste your time. If you get edema, you might be confused afterwards. So, and remember that the RVOT is thin structure. Don't go high, and you have to watch for the contact force and for the impedance and the temperature and the flow. When we went 50 watt in this right coronary cusp, because you can go 50 watt. You will show us the graph of the impedance and this stuff?
Yeah.
Yes, please.
So as you can see at the beginning, here we had an impedance drop from 120 till around 100 ohms.
And this is accepted?
Yes.
If it drops more, this means you are going to perforate.
Exactly.
If it goes high, this means that you are making a thrombus.
Exactly.
These technical points are very important to understand for any operators, in order not to see that you perforated the patient and didn't know why, because you didn't understand that you are on a thin structure. Contact force help you to minimize what you're doing and to help save the patient. So that was a successful case of a PVC which has origin from the right coronary cusp and was suppressed mainly from the right ventricular outflow tract posterior septum, and we ablated it. And thank you very much, Wael. Thank you for the technology of Abbott with the Insight X.
Thank you.
Shukran.